Good morning, everyone. Welcome to the Baker Institute. I'm David Satterfield, Director of the Institute. It's my pleasure this morning to welcome you all to today's discussion on the future of Medicaid in Texas. As we gather here in Baker Hall, we're reminded of the critical role that Medicaid plays in providing access to health care for many millions, tens of millions of people across our state. It's essential that we consider the needs of all communities and work together to ensure that Medicaid continues to serve as a lifeline for Texans in need of health care coverage. Now, Medicaid plays a critical role in shaping the health and well-being of individuals and families across our state, particularly for children, low-income adults, seniors, and individuals with disabilities. As we navigate the complexities of healthcare policy and funding, complexities of, to use the term conservatively, unprecedented dimension right now, it's essential that we engage in informed dialogue, bringing together expertise from policy leaders, healthcare advocates, and researchers. Now, today we are very fortunate to have a distinguished panel of speakers who bring deep knowledge and experience to this conversation. Our moderator for today's discussion is Elena Marks. Many of you know Elena as a dedicated leader in health policy, and she'll help guide today's conversation to ensure thoughtful and insightful discussion. I'd like to introduce Robin Rudowitz. Robin, Vice President and Director for the Program on Medicaid and the Uninsured at the Kaiser Family Foundation. Robin brings invaluable expertise into the evolving landscape of Medicaid and its impact on both individuals and our broader healthcare system. We're also honored to hear from Dr. Andrea Karakostis, of the Asian American Health Coalition, also known as Hope Clinic. Dr. Karakostis' experience in working to bridge healthcare gaps for underserved communities in Texas is vital to understanding the specific challenges that Medicaid recipients face in our very diverse state. Terry Anstey is a healthcare attorney from Disability Rights Texas, whose legal expertise provides a critical perspective on the intersection of healthcare access, rights, and advocacy for Texans with disabilities. And last but not least, we are honored to welcome Stacy Wilson. Stacy serves as the president of the Children's Hospital Association of Texas, representing 11 nonprofit children's hospitals across the state. Her expertise in Medicaid, behavioral health, maternal and child health care, and telemedicine will provide important insights for today's discussion. Now, one business item. You will know on the center of your table you see a QR code. Use that code, please, to submit your questions for the panel, just like a restaurant menu choice. Touch-free. With that, I want to thank you again for being here at the Baker Institute. I look forward to an engaging and thought-provoking conversation. Please join me in welcoming our speakers.
Walk right in front of you all. Okay, good morning. Thanks for being here, and thanks for those of you who are watching online. We are living in some unusual times in terms of what might and might not be happening at the federal level regarding all sorts of issues, including the foundations of our health and healthcare delivery system. Here's what we want to try to do this morning. Robin is a longtime expert in Medicaid at the federal level, so she's going to share some slides and give some basic information about what Medicaid is, who it covers, and a little bit about who in Texas is also impacted. And then she's going to talk about what the potential cuts are. We've heard that there's going to be $880 billion of potential cuts that could happen to Medicaid, and she's going to talk a little bit about what those will look like. She's going to keep it at a pretty high level because although some of us can get really wonky on this, we want this to be an opportunity for a general audience to take away high-level points about potential potential threats and cuts. And then we're going to talk about what is the practical impact if those cuts take place in Texas. And so you're going to hear from Andrea, who runs one of our best community health centers, about the role Medicaid plays for community health centers and their patients and what's at risk if that funding goes away. Then you're going to hear from Terry, who represents disabled patients across the state, most of whom are the beneficiaries of Texas Medicaid. And you're going to hear about the kinds of people they serve and the kinds of benefits they get that could be at risk if we lose our federal Medicaid funding. And then finally, you're going to hear from Stacy, who represents the children's hospitals across the state. Almost half of our kids in this state are covered by Medicaid, and so if you talk about Medicaid declining, the children's hospitals and their clinics are going to be hit really badly, and Stacy's going to talk about what's at risk for those of us who rely on children's hospital systems. So with that, I'm going to turn it over to Robin, and we'll go Robin, Andrea, Terry, Stacy, and then we'll do Q&A. So thanks so much for being here with us.
Good morning. Thanks everyone for coming, and I am also looking forward to a really great discussion. I'm so happy to be here in person. It's much nicer to present in person. So just a quick overview before I dive in on KFF. So we are a policy, polling, and news organization. We are nonpartisan, and we put out all of our information for free on our website and a lot of state-by-state information. So just to let you know a little bit who we are. I've been here for 20 years, so have followed these debates for quite a long time. But I did want to provide this very high-level overview, and I'm really excited and looking forward to the panel to put a little bit more people and on-the-ground perspective. But Medicaid is really complicated. It plays a lot of different roles in the healthcare system. We all know its role in terms of coverage across the country. It provides coverage to 1 in 5 people. About 80 million people across the country are covered by the Medicaid program, a little bit lower in Texas, so about 17% of the population. Medicaid also provides really critical services and benefits for people who are also eligible for Medicare. So about 12.5 million people across the country are eligible for both Medicare and Medicaid. And Medicaid is the program that really helps make the Medicare program work. So it helps pay for premiums and cost sharing for people duly eligible. And it also pays for long-term services and support. So a lot of people don't realize that Medicaid, not Medicare, pays for long-term care in our country. Medicaid pays for over half of all long-term care financing. Medicaid also provides a lot of money for states, and I'll show you a little bit about the implications for Texas, as well as hospitals and other providers. And it really can be used as a lever to help address key challenges across our healthcare system, including social drivers of health, as well as maternal health. Medicaid, since it was enacted in 1965 as same time that Medicare was enacted, but quite different than the Medicare program in that it is an entitlement. So it's an entitlement for people who are eligible for services, but it's also an entitlement or guarantee to states for matching dollars from the federal government. And that becomes very important when I talk about some of the changes that are afoot at the federal level. It's also a partnership. So Medicare is really run by the federal government, but Medicaid is a partnership between states and the federal government. So the federal government sets these very broad rules around the program, and then all states really administer their program in quite different ways and have that flexibility to do that. When we look at spending and enrollment in the program, Texas is pretty similar to other states across the country, where the large number of enrollees on the program, so over half of enrollees in the program are kids, but most of the spending, so $6 and $10, that are spent on the program are really for people who qualify on the basis of age or disability, because individuals need much more complex healthcare services and long-term services. When we look at where the money goes in terms of Medicaid, again, Texas is pretty similar to other states across the country. Across the country, over half of dollars go to managed care organizations. It's even a higher share in Texas. So close to $7 and $10 go to managed care companies. So the state delivers services through plans. Close to, over 95% of people who are covered by Medicaid are enrolled in some type of managed care plan in the state. And Medicaid is quite a complex and important role in state budgets. So it's the largest piece of state budgets. It has it's a spending item, but it's also a really big revenue source. So when you look at state-only dollars that are spent on the Medicaid program, it's second to what states spend generally, and in Texas on education dollars. But in Texas, there's even a higher share of Medicaid dollars that come from the federal government. Again, across the country, it's just over half. And it's about 2/3 of all federal revenues that are coming to states are coming from Medicaid. Medicaid provides a really important role in helping people access the services that they need relative to people who are uninsured. People on the Medicaid program are much more likely to have a usual source of care, see the doctor when they need to, not get their prescriptions when they need to, and not go without needed care. Of course, the Affordable Care Act that I think next week is the 15th anniversary of the passage of the Affordable Care Act. Required states really to provide coverage and expand coverage to low-income adults, but then there was a Supreme Court decision shortly after that challenging the constitutionality of the law, and that effectively allowed states the option of whether to take on that Medicaid expansion. There are now 40 states in the District of Columbia that have now adopted and implemented the expansion. Texas is one of 10 states that has not adopted the expansion. So what that means in Texas is that there's very low coverage for adults who are, so parents at very low income levels are eligible, but adults without dependent children don't have access to the Medicaid program, and there's a coverage gap, basically, so people are not eligible for Medicaid, but if you have incomes below poverty, you're also not eligible for subsidies in the new healthcare marketplaces. Texas has very low eligibility for parents, so in a family of 3 individuals or families making about $4,000 a year, that's the cutoff for eligibility for coverage. And when we look at the entirety of the 10 states of people in the coverage gap, we know that about 40% of the 1.4 million people who are uninsured who fall into that coverage gap are in Texas. So I think that is all background that gets us to the current situation. I think March Madness kicked off, so we're in the March Madness of federal debates about what's happening in Congress and what could potentially happen to the Medicaid program. And I'm not going to spend a lot of time going through each and every one of these proposals. I think some of them, are not likely to affect Texas. So the first 2 on the list are, there's a lot of target and potential changes to the expansion population, so that wouldn't affect Texas. There's also some changes to the federal share, so how much the federal government is going to pay, and there are some states that would affect more disproportionately. But there are a number of proposals that would affect all states, and I will, including Texas, so I'll talk about those at a pretty high level. But I do think the proposals are pretty complicated, but when the federal government makes changes that would change how much federal money is available for Medicaid, the bottom line is that they all have implications for states. So all of these proposals would shift costs to states, and then it's really the states that, and every state might respond differently, the states would need to make decisions about how to respond. And there's not great options at the state level. States can raise taxes. No state really wants to do that. States can cut spending in other areas of their budget. You know, education, again, is the biggest piece of state budgets, so that's not really popular. Or they can cut Medicaid services and benefits and coverage, and that's really hard to do as well. So these all have implications for states. So at KFF, we've done a lot of modeling and analysis of some of these proposals. So the first one I'm going to talk about is this per capita cap. And again, it's a little complicated, but again, right now states get dollars from the federal government without a cap. And this policy essentially would cap federal dollars to states on a per enrollee basis. So if costs of coverage, you know, drug costs exceed this cap or other costs exceed the cap, then states would be left to make these decisions about what to do. So, you know, again, raise taxes, cut benefits to make up for the lost federal dollars that would be available. We've done estimates nationwide and looked at various scenarios, and you know, it's really hard to do these estimates because again, every state might respond to potential changes in a different way. I think the important thing with this kind of policy is that it might not be that impactful when it first starts, but because of the cap that is tied to inflation factor, you know, these cuts get magnified over time, so it becomes more problematic later, you know, like maybe 10 years, even after the budget window that most federal policymakers look at. And again, really down the road would have very big implications for states. Another policy that is there's a lot of discussion about at the federal level is imposing work requirements on Medicaid. So there's a notion that many adults on the program are not working. It's really unclear who this would apply to. So again, it's not clear if Texas would, enrollees in Texas could be subject to this kind of requirement, but it is also important to know that when we've looked at the data, we see that 6 in 10 people are on the program who are adults are already working or face a barrier to work. So the effect of some of these proposals is people wind up losing coverage because they can't verify that they may be working or you know, have some type of an exemption. But when you ask people about these policies, of course, people think, you know, people who should be working, so they are, you know, somewhat popular until you get down to the actual administrative issue of implementing that kind of policy. And then the last policy I'll talk about is these provider taxes. And I know Stacy could talk more about these. Again, it's a really complicated policy, but states right now make up, you know, the states have to pay their share of the Medicaid program. And states make up their share with, you know, general fund or regular tax dollars, but also some of these provider taxes. So all states use these kinds of taxes to help make up their state share of spending, including, you know, on multiple providers, so hospitals, nursing homes, managed care organizations. Texas, you know, has many states have multiple of these provider taxes. There are a lot of rules around provider taxes, so, you know, and one of the rules is there can't be, you know, what's called a hold harmless. So states can't give back to the providers exactly what they paid. And there is a limit on that, and the federal government is looking at changing that limit. Again, a policy that's really complicated, but the effect would be to limit states' dollars to spend on the program, which then leads to, again, these tough choices in terms of making decisions about how to respond to less federal dollars. There are also a number of rules that were passed or made final in the last administration, and I think these are also, there were rules to make eligibility and enrollment more streamlined. Congress is thinking about overturning those rules. There were 2 rules that were pretty comprehensive related to managed care and access. The federal government is also looking at potentially legislatively changing back those rules. And there was also a pretty significant rule related to nursing home staffing. that would require certain levels of staffing in nursing homes. It was the first one of its kind, and Congress is also thinking about potentially rolling back those rules. We did some analysis on the nursing home staffing rule, and there's less than 1 in 5 nursing facilities are meeting the current levels that would be required in the rule. Texas is even lower than that, but again, these rules are the future of these rules is quite uncertain. And then one other area that we're watching is what happens with these demonstration waivers. So this is an issue that is not related to congressional or federal legislative action, but every administration could use these types of demonstration waivers to advance different priorities. And of course, one administration might have very different priorities than another. So we'll certainly be looking to see what happens outside of the legislative process related to some of these demonstration waivers. I just wanted to end with two things. I think, there's certainly the people aspect of how many people could be affected. That makes passing federal legislative changes difficult. The implications for providers is another issue. But I think the other issue that we've seen policymakers run up against is polling, and just how many people have favorable views of the program. And we see that, and we've consistently seen that in our polling. Across every demographic, there's really high favorability for the program. And the other statistic that I always am really shocked by, but over 50% of people say they have a personal connection to the Medicaid program. So they themselves or a family member have been covered by the Medicaid program, and that grows to 2/3 of people have some connection to the program when you ask about a close friend as well. So it makes it really difficult to enact very broad federal changes when so many people have a connection. And that goes to, we just did some analysis on enrollment by congressional district, and all congressional districts have people who are affected on the Medicaid program across all the eligibility groups. So again, the reach of the program is pretty wide. So that was a whirlwind tour of Medicaid and some of the policies, but I'm really looking forward to the panel.
Thank you. Good morning, everybody. And thank you, Elena, for inviting me to be here. Cutting Medicaid would be disastrous for community health centers like Hope Clinic. On an average, about 40% of the patients of a community health center are covered by Medicaid. But more importantly than that, Medicaid provides a reimbursement methodology to health centers like Hope Clinic that make the health center whole for its services. So the payments that we receive from Medicaid include ancillary care, for example, translation, in some cases transportation, care coordination, navigation, eligibility. And all those services are covered by the reimbursement that we get from Medicaid. So a cut in Medicaid would decimate community health centers. We absolutely could not keep our doors open without over 60% of our funding. So maybe 40% of our patients get Medicaid, but it makes up to 60, 70% of our funding. I think that from that point of view, it would be incredibly disastrous. I think most importantly, here in Texas, our children would be affected, our children and our pregnant women right now. So while 40% of our patients have Medicaid, it makes up 90% of our kids get Medicaid, and about another 80% of our moms are covered by Medicaid. So you're talking about very vulnerable populations that still need to get care, and the care that pregnant women need is not cheap. Seeing an OB, delivering a baby, all the complications in the labs that you need to do are expensive. And if it wasn't for what we get from Medicaid, we would definitely not be able to support the delivery and the pregnancy of our moms. And that brings us to the future. what are we going to do when we're delaying basic care for kids and moms? And then, so 10 years, 20 years down the road, we will be paying 3 times more in complicated healthcare issues that this population will develop. So I think it's really, it's a story of people. And it's a story of really helping our legislatures understand the wide impact that decisions like this take over time. Without health centers are the backbone of America's health care. We provide care to about, I want to say 3 of every 10 US citizens receive care from a community health center. And sometimes, like Hope Clinic, you would not know you're in a community health center because we really take pride on the facilities that we build and the care that we provide. So the impact of decimating the backbone of America's healthcare system will be much larger than just the Medicaid population.
Well, I want to start off with some numbers. As of June 2024, about 4.2 million people in Texas are in Medicaid and CHIP. And the estimated number of people with at least one disability in Texas is about 3.5 million. That's about 12% of the population. Of that number, over 1 million people with disabilities in Texas receive Medicaid, and that's at least 1 in 3 people with disabilities. Now, some people with disabilities, they have supplemental security income, or SSI, and that allows them to be automatically eligible for Medicaid. But there's some children who have severe disabilities like cerebral palsy, or they're born with a syndrome with a lot of medical complications, who can't get SSI due to their their parents' income is too high. And many of these children are in Medicaid waivers, like the Medically Dependent Children Program. And meeting medical necessity for a program like the MDCP is how children receive Medicaid. The regular mandatory services in Medicaid and the extra services in the waiver program, like respite care to give parents a break, minor home modifications to help make the home what it needs to be for a child with a disability, for example. Why is this so important? Medicaid waivers and programs like the Medically Dependent Children Program, or MDCP, for children, and also, for example, institutional Medicaid for people in nursing facilities. These are optional pathways to Medicaid, and waivers contain optional services for only for people in that Medicaid waiver. Now, large cuts in Medicaid, the cuts that Robin was talking about, no matter the form that they take, block grants, per capita caps, or reductions in the federal medical assistance percentage, or FMAP, they're going to shift significant costs to the states. And if the states cannot, or in some cases will not, fill this gap, it's conceivable that optional services like Medicaid waiver programs and optional pathways to Medicaid will be on the chopping block first. Less money to spend on these optional coverage groups and services could mean less people are able to be covered in Texas. Tighter eligibility requirements. In fact, we're already seeing this with MDCP. Longer interest lists for waiver programs that are already excruciatingly long. Children wait for intellectual disability or developmental disability waivers like CLAS and HCS 15 to 20 years already. States also can cut services within the waiver programs themselves. Remember, all those services are optional. And I don't even want to picture this. I shudder to think about this. But a state like Texas could eliminate waiver programs altogether. Or they could just let a waiver program expire and not renew it with the Centers of Medicare and Medicaid Services. And just a little bit about potential work requirements. Robin touched on it a little bit. I think it'd likely be aimed at Medicaid coverage for parents of low-income families with children who get Medicaid, and then the parents get Medicaid as a result. In other words, non-aged, non-disabled adults. That group is supposed to be excluded from work requirements. And that means typically adults like 18 to 55. Another way to see it, people getting Medicaid who don't get SSI and SSDI. Now, a few years ago, it didn't work in Arkansas, and there's major issues with Georgia's system. And Robin mentioned these things, not recognizing or applying exemptions. red tape with the reporting requirements that they are working. There's also issues with people who have seasonal jobs or their income fluctuates, and and the resulting loss of Medicaid each time they go up or down, or they can't show that they're working.
Well, thank you, Elena, for having me here. I really appreciate it. Want to talk about two things. The first is the importance of children's hospitals, because that's my job. And then the second is really the importance of Medicaid to those hospitals, because I think that kind of gets lost in the equation sometimes. 1 out of every 10 children in the United States lives in Texas. So really what happens here does drive what happens in the rest of the country. Our hospitals care for newborns to 20-year-olds, depending on their condition. That requires higher staffing. It requires a lot of specialty care that we subsidize those specialists to be here for our kids in Texas, because Medicaid does not pay the cost of what it costs to provide those services. And we want to make sure those services are accessible to every kid that needs one. And when you walk into a children's hospital, it's a different feel. And it's not like somebody says, oh, I'm sorry, you're Medicaid, you go to the left. Oh, you're commercial, you go to the right. That's not how it works. So what we know is that Medicaid is a backbone, to use our friend's phrase here, for what we do at children's hospitals. We make sure that kids have access to school. We make sure that they can play, because a lot of these kids are in our hospitals for very long periods of time, especially if they're getting treatment for cancer, treatment for other things that are really life-threatening. About a third of the care that we provide at children's hospitals are transfers from other hospitals that couldn't handle the acuity, the level of need that child had. So often we are the only place that a child can get the care that they need. We want to make sure that care remains available, and Medicaid is just so important to what we do every day at children's hospitals. I was at the Texas Children's NICU, the Neonatal Intensive Care Unit, which I can almost say, several years ago, and there was a mom there who was holding her newborn. And I asked her if she would tell me her story. And she said, I was told my pregnancy was not viable by my obstetrician, and I was told there was nothing I can do. So I went to go get a second opinion, and my doctor said, go to Texas Children's. She went to Texas Children's, and Texas Children's has surgeons that can operate in utero on the fetus, on the baby before the baby is born. They corrected the problem with the baby. The baby still has challenges, but that baby was born. That mom was holding that baby in that NICU. And without Texas Children's, that would not have happened. And we want to make sure that care remains available to all kids. One of the things that we've seen recently is COVID has really done a number on our children, both for physical health and mental health. The chair of pediatrics at Dell Children's told me that in her entire career, she has never seen kids that have this much medical complexity, whether it's mental health or physical health. And why is Medicaid important to that? At children's hospitals, 60% of our inpatient days are paid for by Medicaid. So you start reducing the amount of payment that we get, and remember, it doesn't cover the cost of care. That means that we start limiting access to those services. Maybe that mom doesn't get that neonatal surgeon because we just can't afford to bring that surgeon down from wherever they trained. We have integrated healthcare systems. So we do a lot of outpatient work in our clinics trying to keep kids healthy. We don't want them in the hospital. We want them healthy and playing and in school. So we do millions of outpatient visits every year, and a lot of those are covered by Medicaid. We've got 3.1 million children, about 40% of the kids in Texas, covered by Medicaid. So Medicaid is a very efficient program in Texas. We didn't expand, as Robin mentioned, and so consequently we are paying, except for pregnant women and 0 to 1 year olds, and for those people that need institutional care, we are at the federal minimums across all populations. So when you start cutting that Medicaid federal engagement down, then what that means for pregnant women, people in institutions, and children is that the state has to make some really hard decisions on whether or not they're going to backfill those federal losses. And in Texas, the answer may be no to that, and you start rationing care. Texas is one of the states that's actually growing in our youth population. We are an economic driver here, and one of the things that we are doing is trying to grow to meet those demands. But depending on what happens with Medicaid funding, not only will we not be able to grow to meet the increasing demands of all the families that are moving here, but we're going to have to think about what care we decide we can't provide any longer. And no one wants to do that. Everyone wants to have, we have shining stars in Texas. Texas Children's is one of the best of the 10 hospitals, children's hospitals in the nation. And all of our hospitals provide excellent, high quality care. We want to make sure that remains available to all Texas families. So that's why Medicaid is so important to children's hospitals.
Thank you. I've got a list of questions that people have put in. I'm going to sift through them, but I'm going to throw one out to start with. The thing that sticks in my mind when I hear Robin and then hear you all on the ground is, and your polling data really backs this up, is how fundamental and integrated Medicaid is as part of the backbone of the entire healthcare delivery system. And so I'm wondering if, let me start with Andrea. You talked about what a large percentage of your patients and funding. Can you talk more broadly? First, tell people what community health centers are. I'm not sure everybody here knows, and their scope and impact in Texas, and talk a little bit more about the kinds of people that you see.
For sure. So community health centers, also called federally qualified health centers, are private nonprofits that benefit from some federal dollars. At Hope Clinic, about 10% of our budget comes from those federal dollars, about $3.5 million, which is not a lot, but it really helps to subsidize the people who have absolutely no insurance. What is so fascinating about community health centers is first that we get that federal input of funds. Patients do pay. They pay on a sliding fee scale. We take all the insurances. And in addition to that, there's also philanthropy and grants that come into the mix. So they're an incredible way of financing, an efficient way of financing healthcare. Some of the mandates that we have in exchange of those federal dollars is to never deny care to anybody. So we have a mandate to see everybody comes through our doors. We also must provide a full scope of services, meaning cradle to grave care, so from pediatrics all the way to internal medicine, dental care, pharmacy services, mental health services, and at Hope Clinic we provide vision care as well. We also must provide access to transportation, translation, and care management. So a really comprehensive type of healthcare services. And in recent years, community health centers have started really moving upstream, working with communities, doing a lot of education, as well as projects that will keep families and communities healthier. So the investment that these dollars make on our patients goes much farther than your daily care. It goes into really changing the status quo of communities, keeping communities healthy, and definitely keeping them out of the ER. And I think that the best investment that we can make in our families and our kids and our moms is preventive care. Give them the care they need when they're healthy, keep them healthy and home so that they can work, they can progress, and they can be a vital economic power for our cities. So when you talk about cuts in Medicaid, what you're really cutting, what you're really hitting is the future of all these communities and of all these families.
Thanks. Okay, I've got a bunch of questions here. We're not going to get to all of them. I'm going to take a really easy one first. Will we have access to the KFF slides after the event? Yes. I saw some people taking pictures of the slides. They'll be, I think they'll be on our website at Baker attached to the event. Okay, here's a harder one, and I think I'm going to start with Robin. I've heard a lot about the scope expansion or scope creep of Medicaid since inception, expanding coverage beyond the original intended beneficiaries, and addition of services and reimbursement beyond the intended scope, especially in some states like California and New York. Can you clarify and comment on that?
Yeah, this is, what is this one?
Yeah.
Yeah, so I think this has come up in the recent debate that Medicaid has expanded beyond its scope, but if we go back to the original slide, that Medicaid was set up as this partnership, and what states are doing and doing differently across states is taking advantage or not taking advantage of various options that were passed by Congress. You know, the Congress sets the broad federal minimums and then also establishes what options that states have. And then different administrations, of course, have ways to promote or not promote various priorities. But there are some states who have used Medicaid as a lever to address other priorities. And I do think California has taken advantage of more options, and we heard that, you know, Texas has not taken advantage of some of the options. But again, that is a state decision based on the parameters that Congress has established.
Thanks. Another question. Sometimes we hear a lot in the current administration, we're not attacking the program, we're just going after waste, fraud, and abuse. And we're talking about $880 billion. Robin, and then you may want to jump into Stacy on whether there's waste, fraud, and abuse, and whether it amounts to $880 billion, and whether these mechanisms that have been talked about as ways to rein in costs address potential waste, fraud, and abuse.
Yeah, that's another, so the scope issue and the waste, fraud, and abuse, I think, are the two issues that we're hearing most about, and I think the Speaker and the President said they are really trying to protect the Medicaid program, but just trying to root out waste, fraud, and abuse. And I think there is no good estimate of what waste, fraud, and abuse is in the Medicaid program. I cannot sit up here and say that it's zero. I don't think anyone could say that it's zero across our healthcare programs, Medicare, private insurance, ACA coverage. These are big, complicated programs, but we don't know exactly what that number is, but it's not anywhere near $880 billion. And I think we're hearing some conflation of, you know, you'll hear these improper payments, which are not a measure of waste, fraud, and abuse, but they're being used in this discussion. And then I think we're also hearing some policy issues creep into this discussion. So you'll hear some people put provider taxes in the waste, fraud, and abuse bucket, but those are really policy decisions. Again, there are parameters that have been established as states can use these mechanisms, use them legally, use them effectively. All states are doing them. So there is a policy discussion potentially about whether Congress wants to limit those further, but they're coming up in the waste, fraud, and abuse discussion in a way that I think is really more of a policy discussion.
Yeah, I would agree with Robin. I think that one of the things that we use provider taxes, and so basically hospitals tax themselves, managed care organizations tax themselves, and those dollars go up matched with the federal funds, and those make up the Medicaid payments. For children's hospitals, 56%, so more than half of all of our Medicaid payments are funded by these provider taxes. And the reason that the state has done provider taxes and the hospitals have chosen to tax themselves is because Medicaid doesn't cover the cost of care. And if 60% of your inpatient days are being paid for by Medicaid and you're not getting your costs covered, you have to kind of think of ways to figure out how you make up that difference, because somebody's got to pay the bills. So I think it's a convenient way of categorizing something that is complicated into waste, fraud, and abuse. Texas is transparent on how we do our provider taxes. In fact, MACPAC, which is the Medicaid Advisory Committee at the federal level, has pointed to what Texas does as a model for other states in transparency. These provider taxes are heavily regulated and they're capped at the federal level. You can only use so much so much provider taxes to fund the state share of the Medicaid program. So all of these regulations are already in place, and we're already well within those regulations. And so I think this is a way of, as Robin said, it's a way of categorizing a policy as something so that they can, do something with it that they wouldn't otherwise be able to do.
I'm going to talk about costs some now. We've got a question here about everyone's concerned about long-term healthcare inflation, that prices keep going up and they go up faster than other prices. And if we're going to try to address that, what are the ways we might do that? And I want to go to Terry with that one because, as Robin's slides showed, most of the Medicaid dollars are paying for aged and disabled people. And so are there cost savings there? Is there something we haven't yet done? Is there cost cutting we could be doing there? Because that's where the real money is in the program.
That's a really hard question to answer.
That's why I asked you.
The waiver programs, they have certain cost limits, that you have to fit in their services within those cost limits every year. So they already can't go past a certain amount, they could lower those cost limits. A lot of them, like for example, for Star Plus HCBS or Star Plus Home and Community-Based Services, that helps bring people out of nursing facilities and back into the community, or prevent people from going into nursing facilities, are already for the community 201% of what it would cost for that person to live in the nursing facility and get the care. Do you lower that? Do you provide less in the community, for somebody, trying to move out, or trying to prevent them from going into the nursing facility? MDCP, for example, is already only 50% of what it costs to take care of somebody, a child in a nursing facility. Do you lower that even further? There's already things that are done for children. Like, for example, the state encourages parents who have employer-sponsored insurance to participate in programs like health insurance payment premium, or premium payment, where if they have employer-sponsored insurance, they can apply for the program, and then the state of Texas will reimburse the parent's health insurance premium that they pay for in their employer-sponsored health coverage. So the states are already encouraging parents many times to keep their health coverage so that they'll use their primary insurance first before Medicaid will pay. So there's already ways that Texas does help to try to keep costs down for children with disability. So.
Combined with what Stacy said, everybody knows Medicaid is a low payer, pretty much
right.
The lowest payer. So the question about what can we do to slow long-term growth, my takeaway from what you've just said is not in the Medicaid program because it's already been squeezed. So we've cut costs as far as we can. Stacy and Robin talked about waste, fraud, and abuse, that if there's some, there's not enough to equal $880 billion. I wonder if you have, any of you, thoughts on the remainder of the healthcare system and what it can do to help let people know the value of Medicaid, and what it can do to help slow healthcare cost acceleration in programs that are not part of Medicaid.
I will take that because I think that one of the important things is that people don't realize they have Medicaid. We see it on our patients every day. They come, they say, I have United Healthcare, and they don't realize it actually is Medicaid under an MCO. And so the realization of the impact of what Medicaid does for our children and our families is not visible. I think that in order to, and what was the second part of your question, Elena?
How can the rest of the system slow cost growth while trying to point out that Medicaid is not the cost driver?
The most important thing to do to slow cost is to do preventive care. You know, that is the one thing that I think the Affordable Care Act was also trying to do, and I'm a big fan of the Affordable Care Act. We had 4% insured patients in our clinic when the Affordable Care before the Affordable Care Act. We have about 32% of our patients have Affordable Care Act now. And couple that with the 40% of Medicaid, a lot of our patients are actually covered, which allows us to do a lot for our patients, bring them in for physicals, do preventive work with them, and educate them about how important it is to stay healthy. So if we cut that off, we're going to look down the road again to starting all over from scratch, trying to bring up the health of a population at a very high cost. So unless we can keep entities that and programs that work on the preventive side, we will never able to cut costs.
And we need to invest in mental health, more mental health for kids. About half of all inpatient admissions for children is for a psychiatric condition.
Wow.
Half.
Wow.
So think about, to Andrea's point about early intervention, having access to counselors, having access to frontline staff that can help them, and then having step up and step down, intensive outpatient, partial hospitalization, which right now Medicaid doesn't cover because they're optional benefits, kind of back to what Terry was talking about. So being able to have access at the level of care that you need, so you're not being admitted for a psychiatric condition, that's where we need to be investing those monies. And the Texas Child Mental Health Care Consortium has done some really good work in that area, but we need to do more.
We've got about 5 minutes left. I want to end on a higher note because I'm an optimist and I'm always looking for silver linings. And I'm wondering, considering RFK Jr.'s emphasis on healthy food, healthy lifestyles, prevention, et cetera, physical activity, if there are potential opportunities within Medicaid to do more prevention and to do more upstream work, and how you see that might take place.
We already have several bills filed in the state legislature that would allow Medicaid to provide food, nutrition, and counseling as an in lieu of service. And they're expanding PE, saying you can't take away people's kids' PE as punishment. There are already things that are happening at the state legislature in response to that kind of Make America Healthy Again movement. So we're pleased to see those efforts.
Robin, at the national level, I think about like the California waiver and the North Carolina waiver, which the Trump administration approved, both put a lot of money into prevention and into community services and into non-medical drivers. How do you see that alignment continuing or not?
I want to end on a positive, but the administration, we haven't seen much in waivers, but one thing that we did see was a pulling of the guidance that was issued under the last administration related to these health-related social need waivers. So they're not pulling back any of the waivers that are already operational and up and running, and they are going to review things on a case-by-case basis. So I think that's definitely an area that we want to look to. As you said, North Carolina is a good example. That was a waiver that was approved under the first Trump administration, and there was a lot of attention on, social determinants of health and where Medicaid can address some of those, so I think we'll need to watch those. And just one other point on your cost issue, I always think it's important that some of these proposals don't, do anything to address overall costs. I think everyone would agree, we should do that, but these proposals don't do that. They cut Medicaid funding, which then makes it harder for Medicaid to buy services in the private market. Because Medicaid is not, the VA, it's not buying its own services. So I just think that's an important overview on the cost side.
Last one sentence from each of you. Stacy, what do you want to leave this group with?
I'm gonna steal Andrea's backbone analogy. Medicaid is the backbone of what we do at children's hospitals. Without that program, those services become unavailable to any child.
Many people with disabilities participate in the Medicaid program. If these cuts happen, it's going to be devastating.
And my thoughts are with the future. I think that when we hurt our kids, we hurt the future of our whole country. Kids need health care to work, to function at school, to attend school. I think that we are undermining the future of our whole country when we pull the rug under the feet of pregnant women and children.
And I think you both used the backbone analogy, but there's another analogy for Medicaid that's the workhorse in the healthcare system. So it's doing a lot of things that other payers don't do, like providing care for people with disabilities and supporting community health centers and children's hospitals. So it's been referred to as the workhorse. So I'll leave it on that.
Well, with that, we're going to call it a day. We could talk forever on this topic. Thank you all very much, and thank you, audience, for attending and submitting questions.
So nice to meet you.